and you're pushing up on the mesial incisal, or occlusal. You're pushing down here, and you're pushing down here, just like you're turning a key. Okay, I'm grabbing this, and I'm twisting it. I'm pushing down on the distal, I'm pushing up on the mesial. So the root on these molars is actually quite mesially positioned because of how the wisdom tooth hit it. All we're gonna do is, because that tooth is partially erupted, but it's not coming any further using the elastic, trying to pull that tooth upright. Okay, let's go ahead and take another look at this case. So we get this patient coming in. He's got some pretty gnarly things going on. Horizontal impacted wisdom teeth, who cares about those? What we really care about is his lower second molar and his premolar. They're blocked out. We're gonna be using auxiliaries to make this easier. The lower premolar is placed towards the lingual. And so we're gonna need to make room, first of all, between his lower first molar and his lower first premolar. Right? There's a tooth that needs to come in between these teeth. Now you could theoretically say, well, let's just go ahead and turf this tooth, but he does have a pretty good overjet. Let's look at his ClinCheck plan. And when you look from the side view, he's got a significant overjet, and he's also got a blocked out upper first molar, premolar. So our goal is gonna be to actually make space to keep all of his teeth. We're not planning to lose any because he's a very constricted and narrow arch, right? I would rather go ahead and focus on developing his arch and not take out premolars because we don't need to take out premolars. We're going to take out these wisdom teeth no matter what because of their horizontal positioning, but we don't need to take out that lower premolar. Now we need to know that we're going to have to uncover this tooth because it's impacted right now. And he's currently, I think, 16 years old, 17 years old, something like that. We're also going to be treating this case with lingual attachments, which is quite interesting. Right? You can see how we're putting all the attachments on the lingual of these anterior teeth, so that when he smiles while he's in treatment, nobody is going to even see or notice that he is wearing his Invisalign treatment or his Invisalign trace. Now, I'm not going to go through his case in the same detail where I go through line by line by line with every single decision, but let's go ahead and take a look then at what we're trying to accomplish. Right? So we see, first of all, that he has a larger overjet. So the first question is, does Bolton matter as much in his case when there's a larger overjet? Well, no. He's a non-growing patient. So at this point, this guy is not going to grow because he's past his pubertal growth spurt. So his canine here is class 2. It's going to change as we make space for this premolar to come into the arch. Just look at the upper. Right? So his teeth are actually going to flare out more. The posterior teeth will retract, his anterior teeth will move forward to make room for that tooth coming in. But the same thing's going to happen on the lower arch. Because on the lower arch, we need to procline these teeth. We're going to have some distalization occurring of the lower molars, but we need to make space for that tooth to come in. Now again, first thing to know is that this is going to take time. This patient needs to understand that his case in total, and I'll tell you right now how long this actually took. It's going to take, I would be telling him it's going to take 2.5 to 3 years. In the end, he started this case in January of 2022, and he finished this case in August of 2024. So it was 2.5 years. Yeah, just checking that. That is correct. Okay, so what are we going to be doing for his case? How are we going to be setting this up? Let's look at the upper arch first because this is the easier situation. Again, I'm not trying to hit a home run. This is not going to be one batch of trays, obviously, right? So what are we going to do? We're going to go ahead and we need to create arch development. So at the end, we need to make sure that we see a beautiful arch form like this. But how do we get there? How do we look at that staging? Well, there's 2 things I'm going to do. I'm going to go ahead and place an attachment on the lingual of this tooth to make sure that it's gripping the tooth and really locking it in place in the tray, so it doesn't just slide out. Oftentimes when you have this tooth that's sitting right there, what's the best angle for you guys from your view? Here's the tooth, right? As the tray tries to move that tooth to the buccal, the tray just slips right off and it slides off that tooth. So that's why we're placing an attachment on the lingual surface. We can't really place one on the buccal because we don't have room. But this locks the tray in place and ensures that we're going to have good tracking. Okay, so that's number 1. Number 2 is I'm going to ask the technicians that what often happens, and it's a huge mistake. Like, guys, this is just like one of the biggest things that is one of my biggest grievances with Invisalign ClinCheck setups is that they don't plan space around teeth that are going to move. So what ends up happening is this tooth will just start moving right from tray number 1, and it will move right into the neighboring 2 teeth. Like it will smash up against them. And if you took a piece of floss and you floss down between those contacts, I'm trying to get my angle right for you. There. Right, you floss between those contacts, what you're gonna find is that it's gonna be like snap, snap. And then you're gonna look at the tray, you're gonna tell the kid to put it on, and you're gonna be like, no, I said put it on. And they're gonna be like, I'm trying. And you're gonna say, well, you're not wearing them, it doesn't fit. They're gonna be like, no, I swear I'm wearing it really well. It's like, well, no, it doesn't fit because the teeth are smashing into each other. So what we are gonna do differently is we're gonna tell the technicians, do not begin moving this tooth, this premolar tooth, until 1 millimeter of space has been opened up mesial and distal to it before that tooth can move buccally. Right? We do not want them to start moving this tooth right away. We need to make space. And this makes sense because this is what is done when you're doing brackets and wires. You would use an open coil spring. So you'd put brackets on right here, right where the attachments are, here and here, and then you'd put a spring between these two and you'd push them apart. And you wouldn't even put this tooth into the arch with a bracket. You would then wait till space opens and then you'd move that tooth. Once there's enough room, you'd put a bracket on and you'd pull that tooth buccally. I'll just show you here. This was the original plan that it had an attachment on the buckle, which we changed to lingual. Now, one thing that I would change that I don't love, and it looked like it might have been better in the original, is we have space opening up, but then you can see that right around here, the tooth starts to touch again. Like there's friction. Well, friction is our enemy. There is 3 things that you need for a tooth to move. That's it. You have these 3 things, tooth will move. You need space, right? If that tooth doesn't have space and it hits against another tooth, it's gonna stop moving. You need space, you need force, you need something to push against it, and you need time. If you have those 3 things, you're golden. But in this case right now, we had the space, and then they closed it. And then now these teeth are rubbing up against each other. Now, traditionally, a line would say, grab a floss or a finishing strip and floss between the teeth to make sure that they don't hit. But that's kind of a waste of your time. Why are you spending that time as a doctor doing that? You shouldn't have to. So I would change this plan. And again, it was actually better in treatment plan number 1 here that the space was opened. And then this tooth starts moving past. It still wasn't perfect because it eventually, oh no, it was pretty good. It hits right here at tray 50 on the one contact and the other one's still open. Yeah, I take it back. The original plan here, number 1, was much better because they only closed that contact at the end. What I would actually do nowadays is I would just literally leave 0.5 millimeter of space, mesial and distal, to this tooth. So if the movement doesn't fully express, it's not that hard to come back and finish moving that. Now, that being said, it doesn't mean that this movement can't fully happen because this is the position at the end of ClinCheck number 1. It actually did fully move. So even though I would have left extra space to make this more consistent, at the end of this plan, I'll show you the pictures in just a second. This is right here, the starting position at tray number 1 of the next batch. So it worked completely fine, even though we didn't open that space. Okay, so that's the premolar situation on the upper. Other than that, the easy way of just doing attachments for lingual attachments is that you place 3 millimeter horizontal attachments. It's really not that hard. And then later on, if you need a root movement that didn't fully express, then you place a buccal attachment to finish off that movement. Now, in this situation, when a patient has lingual attachments, this patient will be eating with their aligners in. And that might sound really gross, but a lot of aligners or a lot of different appliances require you to eat with them in. The first one is braces. Or imagine this patient wanted lingual braces. This is just the same thing as lingual braces. It's just that there's some stuff on the buccal. But the patient's going to eat with their aligners in. As soon as they finish eating with their aligners, they must immediately take them out, brush their teeth, brush their trays, and put them back in. They always have to brush after they eat. And there's never a circumstance that they ever have sugary or acidic drinks with their trays in. Pop, soda, juice, energy drinks, they always come out for that. Tea, beer, coffee, wine, those are fine. Drink them. When you're finished drinking them, take your trays out, rinse your mouth, rinse your trays, brush your teeth, pop back in. But that's the protocol for this patient. The other thing you'll notice is that this patient will actually be changing out his trays every 3 days. So he's not changing out his trays every 7 days, because when he's biting down and occluding with his trays on his teeth, the trays push on his teeth more and the movements happen more consistently. And so there's a synergistic effect from the chewing forces, pushing the trays more. He's also not taking his trays out for 4 hours a day, because if you take out your trays for 4 hours times 7 days, that's 28 hours per week, an entire day's worth per week that the trays are out of the mouth and the teeth are moving backwards. Again, I cover this a lot more in attachments and biomechanics, if that's of interest to you, learning more about lingual attachments. But essentially, this is the protocol that we did in his case. Again, we crack space, we do arch development. This is super consistent. This will happen all day, every day. It will work. Things that are a bit more complicated with his case is actually kind of this sleeper situation, that his second molar is actually quite mesially inclined. So the root on these molars is actually quite mesially positioned because of how the wisdom tooth hit it. When we look at his ClinCheck, we actually need some distal root tip. And that's put into the plan to some degree, a little bit of it. But we actually don't have the right attachment situation here for distal root tip and for arch constriction. We really need to have an attachment more on the distal aspect of the tooth, because that's where we're going to put, that's going to be pushing down against to create some distal root tip. But again, from arch development standpoint, this is a consistent plan. It will be successful in terms of the arch development. I can tell you that every single day. On the lower arch, we need to create space. Well, to create space means that we need to have enough attachments on the teeth for the trays to lock in place, and then we crack open room. Now, we're not planning to put on I don't believe, a pontic, no pontic, no eruption compensation, because we know that this tooth is not going to start magically coming in on its own to the point that it's going to hit the tray and cause the tray to stop fitting. This tooth could start coming in a little bit on its own. I shouldn't say that, but we know that it's going to take some time before it's up high enough that it's actually going to hit anything. And so for that reason, again, we're not going to go ahead and do anything other than crack space to start with. But again, opening up space where a tooth is blocked out is very, very consistent. Like, this will work. I can tell you that. 100%, this will work. We have attachments on the buccal and the lingual to really make sure we lock in. But this will create a lot of space. Now, we have some elastics that are going on. One of them is running from the, let's just look at these two slits on the bottom here. We have a crossbite, right? We have a crossbite on this second premolar, sorry. But we have the crossbite going on. And so we're going to be using these slits here to run a crossbite elastic. And we also have the button cutout on the 7 that we can run to the lingual of this tooth, which is going to have a crossbite component to it, but it's also going to have a class 2 component. Now, we know there's not a lot of growth at this point because this patient's 16 or 17, but there might be a little bit of growth we can take advantage of. Same thing on this side. That's why we have the button cutout right now on the 6, running to the lingual of the 4, because even though we know that there's probably very little growth left, we're going to see how much growth we can possibly get to try and get as close to class 1 as possible. But we are absolutely having the conversation with this patient from the beginning that he is for the most part, non-growing. And so we'll take advantage of whatever late growth he has, but we are not expecting that we're going to finish in a perfect class 1 occlusion, because let's put the bite jump at the end of treatment. When you look at how much anterior posterior correction is needed, it's many millimeters. There's like 4 millimeters. So we don't fully expect that that's going to happen. Now, one thing we're going to plan for in his case is that we're actually going to do the uncovering. We'll do the surgical uncovering of this tooth and put a little hook on it. We did it pretty early on. We could have done this later, but we actually just surgically uncovered the lingual aspect of this tooth right here at the beginning of treatment. And we're going to be putting an eyelet on it, right? Something that has essentially like a little hole that we can loop through whatever we need. This doesn't actually get used in his first ClinCheck because again, all we're really focusing on, like what are the main goals of this plan? Arch development and bring this tooth into place, open up space for that lower premolar. And then the other component here, which is going to be that on his second molar on the lower, we are wanting to bring this tooth into the mouth. Let me jump to the ClinCheck. We're wanting to bring in place his second molar. Now, because we're taking out the wisdom tooth, the good thing is that we're going to have access to that second molar at the same time. So to start with, we're going to go ahead and keep things simple. We're just going to go ahead and run an elastic from this tooth here. And actually, this is what I should make a correction on. We're running an elastic from the lower second molar to the upper premolar. So we put the button cutout on the 6, but we're also going to just try and run the elastic from that lower wisdom tooth, which is not in the plan right now, up to that first premolar to try and help extrude that tooth. Right, we'll see how much that can happen on its own. And then if it's not successful, then we'll resort to other options. So this is what it looks like. Here's our button on the 6. And then on the 7, after we've surgically uncovered that tooth, we're seeing how much will this tooth erupt on its own, first of all, and then how much could we accomplish by hooking an elastic onto that tooth and running the elastic in a class 2 orientation. As we make some space for this tooth, again, we haven't actually used anything on that premolar, this tooth does start to come further into the mouth. Now, again, we did not have a pontic eruption compensation, which is fine. But at the end of our first batch of trays, this is where we're at. We talked about how consistently that premolar will move into the arch if we create space and we put force from the lingual surface. Looks great. On the lower, we talked about how if we just have the right attachments on to lock the trays in place, we can create space. And this tooth does erupt more on its own. In reality, we probably shouldn't have even done the uncovering. We probably could have just left this guy here and then addressed this on the next batch. And in the back on the second molar, this tooth has started to come in a bit more because of how we hooked the elastic on to run the class 2 elastic. So this is where we're at now after our first round of aligners. Let's go to this plan. So we'll look at tray number 1, second round. So this is what we accomplished, right? Again, is this a bit of a mess? Sure. He's hitting heavy on his first molar. His bite is propped open. But do we have nice arch form now? Yeah, we do. This is getting a lot better. Do we have space now for the lower premolar? Yeah, we do. And is that lower second molar starting to come in more because of how we just used it for the class 2 elastic situation at the same time? Yeah, we did. Okay, so where are we at now at this point? So at this point, we look at this first, let's look at the upper again. We look at the second premolar, and you can see that the palatal cusp is hanging further down. So how we're going to address this is the same actually as what we're going to do with these second molars, that those teeth need more root tip, is we're going to be going ahead and placing attachments on the buccal. So actually remove the attachment from the lingual surface. And now, again, just focus on the premolar first. Really working on creating buccal root torque. And so the buccal aspect of this tooth is moving, of the root is moving. So how it looks on the ClinCheck is it shows intrusion occurring on the palatal cusp. So I've just asked the technicians for 10 degrees of buccal root torque beyond the normal amount. That's what my instructions would say. But you could also go ahead and you can actually plan this in yourself and put in a buccal root torque. Let me show you how you do that. I'm going to modify his final plan. Again, I kind of always spoil it a little bit when I jump ahead here and I'm like, oh, here's where he finished. But if you wanted to add buccal root torque, you'd click on the tooth. So here's our root torque buccal lingual. I'm going to click on this. So it shows the arrow where the root is. And then we click on this and we drag it towards the buccal. That's it. And you'll see the number here for the buccal is getting bigger. Right? We could do the same thing on the 6. And on the 7, we could click on this and theoretically you can even just type in a number here. You could type in 10. And let's go root I might have to, there we go. Buckle and go 10, enter, boom, done, finished. You can do that yourself. So that's how you can actually make the modification yourself. And if you want to add the features like the attachments we're talking about, again, you just drag it and drop it. Then I might click it, pull it to its max thickness. Easy stuff. Okay, so that's the completed plan, but let's go back here to our in progress plan. So that's how we add the buckle root torque. And the second component here is we need this distal root tip. So what I'm trying to accomplish right now is I'm trying to accomplish the root moving on this second molar towards the distal. We're trying to create distal root tip. So how are we doing that? Well, we're actually placing, in this case, some pretty big attachments. We're placing two, what are they, 5 millimeters. So I'm making essentially a 10 millimeter wide attachment. And then I'm placing two of them directly on top of one another. So you can only place one attachment yourself on a tooth. To place more than one, you have to ask the technician. Let's see when it shows up here. And then I'll find the instructions. You need to ask the technician to actually place two attachments on the buccal surface, and then you can kind of manipulate them. So I started with just one attachment and realized, you know what? I need an attachment on the distal aspect to create distal root tip. Remember, tip is referring to the mesial distal orientation. Torque is referring to the buccal lingual. So it would have came here on treatment plan number either 9 or 10, I'm thinking. Okay, here it is, number 9. So on number 8, I think unfortunately because these plans are pre-existing and I'm looking at the copied, I believe I had notes that would have asked them here. I don't think it's keeping my, because this is a copied plan, like a study case. It doesn't show my comments except for the accepted case, but my comments here would have said, please place two 5 millimeter attachments side by side to make a 10 millimeter wide attachment, and then double stack them by placing an attachment directly on top of the first attachments. Again, unfortunately, it doesn't show that in the instructions, but that's what I would be asking for. So now think of turning a key here, right? It's almost like you're grabbing this attachment and you're pushing down. I'll just draw it for you. You're pushing down on the distal gingival, and you're kind of pushing up on the mesial, or you're pushing down on the distal gingival, and you're pushing up on the mesial incisal or occlusal. You're pushing down here and you're pushing down here, just like you're turning a key. I'm grabbing this and I'm twisting it. I'm pushing down on the distal, I'm pushing up on the mesial. And that's what's focusing on creating the root tip. Now, it's not necessarily going to be completely successful because this is a very hard movement for both brackets and wires, as well as for aligners with the attachments. On this side here, we're getting the distal root tip and we're getting that root torque. On the lower, I've now actually put some button cutouts here because what we're going to do is we're going to place virtual, or we're going to place C-chain, which I'll show you the drawing of. So this is what we're actually planning to do on the lower, is I realize that we need to spin this tooth and rotate it. But I also need to bring that tooth buccally. The aligners are not going to be effective at grabbing that tooth because it's only partially erupted. And who knows how long it will take for it to fully erupt. So instead, what we're going to do is we're going to use two different C-chains. So C-chains are just what you put in over top of the brackets and wires to tighten contacts. And what we're going to do is very cool. We're going to do a slingshot technique, and we're also going to focus on spinning this tooth. Now, I've never seen anybody do this before. Nobody showed me how to do this. I didn't learn it from a master. I literally just thought of the mechanics and was like, hey, let's do that. So I hook the C-chain here to the eyelet, and we're going to connect that to the attachment that's going to be on the 4. That's going to spin the tooth. So the blue one is going to spin the tooth. And then we put a Kaplan hook as well, like another little button here on the lingual. And we're going to run an elastic that's going to go underneath the contact. and it's going to slingshot the tooth evenly from both sides. Let me go ahead and show you what it actually looked like then. It's a little bit hard to see, but this is going underneath the contact, below the gingiva. It's going underneath this Kaplan hook, and then coming back around and connecting to the button. But it's, again, kind of underneath the gingiva. So that's coming around underneath, and then on top of this is running our, over top of that, then just running in this spot where it's the blue, is actually this green C chain that's then pulling the tooth and spinning it. And all the ClinCheck is doing in this situation is just, we need to have spots for the button cutout, right here and right here, that's fine. And then this one's just for the class 2 elastics. And we're just creating a bit more space. The cool thing is that the aligners, even with the C chain, the aligners will always be stronger than elastics. The aligners are actually very strong. So they will create more space. They will not be overpowered by the elastics, which just seems kind of crazy, but it is true. So here's where we're at right when the elastic and the C chain goes on. This is how it starts to derotate the tooth. And again, we're changing the C chain out like once a month. And it's slingshotting that tooth into position until we get to this spot here. Again, from here, derotate the tooth with the green one, and then the black one runs underneath the contact, underneath this little button, and pulls that tooth towards the buccal surface. That's it. Maybe it seems complicated, saying like, well, how did you know, Stephen? How did you know to go ahead and do the slingshot technique and try to derotate that tooth at the same time? And the honest answer to you is, you didn't have to do it necessarily. You could even just go ahead and do that little slingshot technique just to bring the tooth buccally, because then we can rotate the tooth later with an attachment if needed. Or again, we could go ahead and use that C chain to spin the tooth, right? In the last lecture, I believe I showed an example of derotating teeth by spinning them with C chain. So all we're doing is we're just combining those concepts together of saying, let's spin a tooth with the C chain and let's slingshot a tooth with the C chain. And let's just do it at the same time. And we'll even use the same button on that lower first premolar. Again, nobody showed me how to do that. It's just, why not? It should work. Let's talk that wisdom tooth. So on this side now, we have a wisdom tooth that's sticking down below the gingiva, and we still need to get that wisdom tooth to extrude more. So how are we going to do that? Well, the way we're going to do that is, you kind of saw a little glimpse of it as I was clicking through, is we're just going to go ahead and glue on a bar to the lower 6. And what we're going to do with this little bar, like all this is just an orthodontic arch wire that has some flexibility to it. I think this is actually a stainless steel one. All we're going to do is, because that tooth is partially erupted, but it's not coming any further using the elastic, trying to pull that tooth upright. So all we go ahead and do is I take essentially in this case, stainless steel, but we could have used Nai-Tai. Nai-Tai probably would have been better actually, but a Nai-Tai square wire, arch wire, maybe like a, I don't know, anything, any square wire, 19 by 19 would work, or 19 by 25, and we cement it in place. And then I use my Sure Scaler or a hemostat or something just to push it down underneath a Kaplan hook. That's all that is. It's just a Kaplan hook. And so it forces it down underneath, and that's now lifting up on that little loop. So we've just kind of spring loaded it. This is active because normally this wire wants to be straight, but instead, because we forced it down and it's trying to regain its original shape, it's pushing up and extruding the tooth using the 6 as leverage. Now, what I'm planning to do on this then is we're going to actually cut out the tray. We're just going to trim it with some scissors, just like last time. On the lingual side, we're going to place an attachment to try and make sure that we're locking the tray in on the lingual so we don't get unwanted side effects. So that's the plan over here. Again, this case has a bit of everything, right? We got a whole bunch going on. I don't expect you to necessarily have the confidence to say, hey, I'm going to take on a case that has a blocked out tooth to the premolar, like on the palate, on the upper, that I need to bring into the arch and create arch development. And I'm going to try and work on a distal root tip on a really stubborn upper second molar that won't move. And I'm going to bring in a blocked out premolar that's impacted by creating space and then using a slingshot technique to bring it in. And I'm going to upright a lower first or second molar at the exact same time using an arch wire that we're gluing in and then bending down to make it active so it will kick that tooth upright. Like, again, I don't do these lectures because I want to give you easy things. I'm doing them because I want you to now recognize how you can address any one of these minor issues, but you can also use them all at the same time. This is the arch wire when it's active, and now it's like spring loaded. I'll go ahead and just cut ahead so you can see what it looks like as that tooth pushes upright and extrudes. So you can see the changes that happen from where the tooth was sitting pretty low to where now it's pushed upright and it's extruded. And again, no plastic is covering this tray at this point. And one of the things that ends up happening though is that the lingual side of this tooth at this point, it needs to extrude more because the buccal has extruded, but the lingual needs to extrude. Well, fortunately, the lingual is extruded enough that I have some access. And if I need more, I can go ahead and use a laser to just trim a little bit of this tissue and do the exact same thing. All I'm doing is I'm putting on in this case here, I don't think oh no, I did use a Kaplan hook again, but you could just use a regular button too. And you could even just theoretically use a blob of composite even. Like you don't need to have a button here, but I glued a button to the tooth and then I put a bunch more of the cement and I glued the wire. I bent the wire down and bent it underneath that Kaplan hook. So then all it's doing is it's pushing up on this tooth, trying to extrude it so that now the lingual side has also extruded. Unfortunately, the photos don't show the best in the posterior. This is actually at the end of treatment now, and you can see how that tooth has completely uprighted and it's now fully in the arch. So that is a technique for how you can extrude a tooth into the arch. On the lower, we had gotten to this point here where we showed how we slingshotted it and we spun it part way. If I was smarter, what I would have done is I would have gone ahead and actually left on the C-chain here, and we would have kept spinning this tooth until it finished its rotation, because that's just going to make things easier, because I don't then need to try and spin and rotate that tooth entirely now with just an attachment, which can be a little bit stubborn sometimes. So that's what I would have done differently, but I didn't. And I'll pull up the ClinCheck for you here. Instead, here's the ClinCheck. So we're using a vertical attachment to work on the rotation of the tooth. Notice how we talk about whenever you have a hard movement, making space around the tooth makes it more consistent to accomplish the movement. And you can even leave space at the end. So I did not do that on the upper earlier, but now I'm going to do that on the lower to try and make this more consistent, get more plastic gripping interproximally. Again, the attachment on the lingual is for the rotation. The attachment on the buccal here is just for retention. It's just to help hold that tray on the tooth and to help it extrude because we need more extrusion. The vertical attachment on the lingual is not going to help the tooth extrude. The horizontal attachment on the buccal will. Okay, so this is the plan. And the other reason why I plan a little bit of extra space around this tooth is that sometimes when it's blocked out still, and it's still partially below the gingiva, the height of contour still is below the gingiva. So we want to just improve that. So here's where we were at before we start moving the tooth with our ClinCheck plan. Again, it would have actually been better just to finish spinning the tooth with the elastic a bit more, but I didn't. Here's where we're at after we've derotated that tooth. Right? So this is again an example for how you can focus on derotating lower premolars that are very stubborn. So this is where we're at. You can see a little bit of space around that tooth. So now let's look at his plan on his ClinCheck. So this is where the ClinCheck is after that plan. Again, it's going to take a number of batches before we get to our final result. So now we can go ahead and focus on some fake IPR around that lower premolar, because all we're doing is just tightening up the contacts. So some fake IPR, some bite settling occurring in the posterior. We'll take a look at these molars in just a moment here in terms of how those movements occurred. You can see we've got a little bit of this tooth now showing. We're still uprating that, but we're getting closer. And let's just take a little trip down memory lane, right? We had that mesial root tip like crazy. We work on significant distal root tip and buccal root torque. We don't necessarily accomplish all of it, so we continue working on more of it on the next batch. We don't necessarily accomplish all of it, but look at the difference from let's just compare treatment plan number 18 to treatment plan number 11 here in terms of that distal root tip. These are both tray number 1s. This is a hard movement. The distal tooth in the tray, the most terminal tooth, especially on, well, upper and lower, but the plastic is not the strongest for creating something like a root tip. So from where we first started to where we are, we've accomplished something like this much right here. So it's still only 50% of what we've actually planned is what we've accomplished, but significant in terms of what, even with brackets and wires, this can be a very, very challenging movement. And if you said, Stephen, I don't want to do it the way you've just done it, I would rather use brackets and wires. Cool, you can, because that's the cool thing here is that I've shown you now how you could go ahead and put some brackets and wires on those teeth. But instead, we keep focusing on using the aligners. And 18 was the one we were on. So this is where we're at after that batch. And then here's where we're at 20. A little bit more. So again, let's just compare number 20 with plan number 11. Make sure they're both set up for aligner number 1. So you can see just how significant the amount of root tip we were able to change. But you need to have the right attachment on this tooth. Like, you need a big boy. And that's not something that Align's going to give you as a standard protocol. So you need to know how to ask for that. Okay, and then with our last batch here, we've actually taken off all the attachments and we're just focusing for the most part. Let me discard this because this is just a sample ClinCheck again. But this is where we were at, and we're just settling the bite now. And anytime we have a bit of posterior open bite, this is how I settle it. I just use some aligners that don't actually have any attachments on them, just to allow the teeth to come back into full occlusion. Again, on the anteriors, we just use those lingual attachments. That allowed us to align the teeth and get them in the right spot. So again, let's just do a comparison on the ClinChecks from plan number 22 to plan number 4, and we'll take a look. So these are both aligner number 1. So this is the actual position on the left of where we first started, and this is the actual position, not at the end of treatment because we're still settling the bite, but on almost at the end of treatment where we're just finishing settling the posterior open bite. So we've completely opened up space for that tooth to come into position. We've leveled the curvus B. We've brought in our lower second molar. We've developed the arch and created some significant expansion. In the meantime, he wasn't good with his brushing and he had to have his upper second molar extracted, unfortunately. Not due to the orthodontics, but just due to poor hygiene. And of course, aesthetically, which is not really the concern here. The concern has been primarily that we need to focus on getting the teeth into the proper position for the occlusion. Okay, let's take a look at his photos. So from where he first started here, this is his aesthetic positioning of the teeth. Looks really good. Things that I was not able to accomplish. I did not get his midlines on because he's not growing. So I can't get the midlines on. We managed to get, again, the occlusion nice and dialed in the posterior by the end of this batch. With the occlusion now, we have nice contacts between all the teeth, but we are definitely in a class 2. Can't change that. I can change a lot of things for him. I cannot change that. And he did have actually a little bit of relapse here. This was straighter previously, and then he wasn't wearing his aligners as effectively as he should be, and so that tooth has started to relapse, which is a bummer. But I would say from where we first started to where we're at the end of this treatment, a significant change. So again, takeaways for you guys is just to recognize the fact that you don't need to know how to do every one of these techniques. I'm guessing that many of you have never seen, even any of these techniques done. But I want you to at least take some of that away, that again, hard cases can be treated with Invisalign. We're not scared of using auxiliaries. They're not hard. You guys do hard things like implants, root canals, extractions, anterior crowns. Like, I'm a fake dentist. I don't do any of this stuff anymore. I literally put bumps on, I don't, my assistants do, but bumps on people's teeth. We give them rubber bands sometimes, which we glue on these little buttons that takes 30 seconds to do. It's the easiest thing in the world. And sometimes we go ahead and we might like put a little arch wire in to like try and uplift a tooth or something like that. But I guarantee you guys do harder things than this every single day. And you can accomplish hard things. You guys are smart. You are great at what you do. And if you put in the time, effort, and energy and you have good mentorship and training, I 100% know that you could do cases like this too. So I hope that serves as an inspiration. For those, I know a lot of you right now are clearly select doctors who are currently on this call, but many of you might not be. So my vision for what we're trying to provide doctors is 5 different things. I realize that I can just go ahead and talk about cases and you'll learn from it whatever you learn. But there's a certain aspect that you need more than that, right? And so the first thing you do need though is knowledge. You need education. So being part of Clearly Select means that you get access to every clearly aligned course in existence and everything that we've done in terms of our previous recorded content. So like for live lectures that you see in these previews, in these breaks. So if you have that knowledge and you have the education, right, there's over 170 hours and you don't need to do it all, but you have different tracks and pathways that you can follow of whether you want to do really complicated things or if you're a brand new provider and you just want to do basics. But we provide that support with the education and we continually put out new content like this. The second aspect is you need to have confidence. You need to know that somebody's in your corner who's got your back and will support you with ClinCheck design. So we have this in 2 different ways. We have this through different chat communities that you can be a part of, but you also have it through our ClinCheck design services that any member who's part of Clearly Select will get access to 10 ClinCheck case reviews done by our team with these thorough overviews like you're seeing right now of full breakdowns of these cases. And so being able to take cases that are slightly outside your comfort zone and helping you work on those so that you become more confident with them, but keeping you in the guardrails so you don't crash and burn is so extremely important. So the vision alone is that any doctor in Clearly Select should be doing ideally 10 cases that otherwise would have been a little bit outside your comfort zone that now you can treat. If you normally treat $6,000 per case and the lab isn't 2,000, but imagine your lab was 2,000. It's actually less than that by quite a bit with Clearly Select. But if your lab was less than that, it would be less, or you'd make more money. But let's just say you made $4,000 on 10 cases. The idea is there's no reason that you shouldn't be making $40,000 after lab by being a member of Clearly Select, because we'll support you and give you ClinCheck designs and keep you in the guardrails for you to take on cases that otherwise would have been outside your comfort zone. So the confidence side, right? So number 1, knowledge. Number 2, confidence. Number 3 is community. You need to have other people who are going through this journey at the same time that you can communicate with and you can bounce cases off each other and get support from them. And so Clearly Select is not just me. We have our faculty and advisory board. And so we're really working on creating that collaborative community to support doctors extensively, not just in orthodontics, but in other areas. One of the cool things is that we have experts in so many different areas in our group, because the goal of Clearly Select is that this is not just your basic education that anybody can join. We're actually pretty strict. Only half the people who apply to join Clearly Select actually get accepted. So the vision is that this is the Rolex of education. We want people who are committed and who really want to improve. So that's the community aspect. The third one is the logistics, the business, and the profitability. We're able to leverage some of the best discounts in the entire industry. If this is something you're interested in knowing more about, we can go ahead and get into the specifics. But on average, our doctors save $30,000 on their lab costs. Again, $30,000 compared to whatever your tier discount would currently be. We also get discounts from other dental companies like dental monitoring. And so with the different discounts and benefits, financial benefits alone, that's substantially worth it. But in addition to that, right, we're going and giving you business strategies through the different courses and through the different lectures that we do, where we teach you about profitability and marketing and how to organize and set up your office to handle scale, right? We do whatever it is, 400 cases per year in our clinic, and I only work 5 days a month. So We're going to help you with the logistics, the profitability, and the business aspect. And then the final point, which I think is to me the most important of all, is accountability. We're going to hold you accountable. We want you to tell us your goals. If you don't meet them, it's not that we're going to kick you out of the group, but I want you to set targets and actions. And again, this is why I think my patients do really well with Invisalign is I'm giving them direction. I'm coaching them. I'm their personal trainer. So we will give you feedback. We will give you goals. We will help provide different tracks of education for you to be successful because you need someone in your corner who's going to help push you. And that's something that I really enjoy. So that encompasses what Clearly Select is, but there's so much more than that. We're working right now on a Wikipedia that essentially has videos to answer every single question. You have IPR, you are putting on attachments, you are doing TADs, you're doing impacted canines, you're doing an impacted lower premolar in 30 seconds, right? We're going to have Wikipedia articles that are going to go through and explain all of this, and they're going to be cross-linked. So you can go ahead and be in one and you can start looking at something else. And you can also use our AI chatbot to actually ask questions to get it to give you answers and then focus you in on the right areas. So there's so much coming with Clearly Select. And I'm excited for all the doctors who are already part of our groups. We currently have over 300 practices that are involved with Clearly Select. And this is something that I plan to do for a really long time. I've still got 32 years left currently until I plan to retire. So if you want to be part of this journey with us, whether it's for 5 years or for 30 years, we'll have the information in the description. We'll also send out an email after this webinar, either tonight or tomorrow. Chris, maybe if you can just go ahead and put in the chat, oh, there it is. It just showed up there. The website where you can apply to be a candidate and be considered to join Clearly Select if this is something that's interesting to you. Again, you don't have needed to ever do a single case of Invisalign. All we ask is that you're committed to improving and that you have a goal towards excellence. Those are the main things.